نتكلم معاه بالتلفون أنا وياه وبحكي معنا وسبريد الاكتيفيتيز اللي عندنا لزملائكم هناك
ان شاء الله.
بالنسبه دكتور اياد عزام، دكتور اياد عزام من الاطباء يعني تعرفنا عليه عن طريق الكلاب، وكمان مبدع، وكان معنا الحلقه اللي قبل الماضيه. اهلا وسهلا فيك. اليوم سبيكر اياد. ها طبعا طلب من اياد انه ما تكون اول كيس، الكيس تبع قلنا له طيب حاضرين بنحطك ثالث كيس.
انا والله لاني لساتني بشتغل على الزوم وهيك لاني انا مش قادر.
ماشي. في عندنا الدكتور من الأردن، في عندنا الدكتور هادي أبو هنطش. دكتور هادي أبو هنطش من الأطباء المرموقين والمعروف لديكم جميعا يعني. أهلا وسهلا فيك يا دكتور هادي.
شكرا.
الدكتور الكرمي من الأردن، عمرو الكرمي. كمان في سبيكر اليوم عمرو وعنده حالي يعني very nice case. طيب
دكتور محمود
بس نبدأ.
بس بدي يعني حاب أشكركم جميعا على تنظيم هاي المحاضرة، وإن شاء الله إنه كل الدعم زي ما تكلم الباشا. بس أنا حاب أحكي كلمة برضو عن الباشا يوسف القصوص. يعني there are a lot of people they call them big deal and the giant interventionalist. He is the giant interventionalist and he is, I think, the first interventionalist in Jordan. I have the privileges knowing him since over the last 20 years or so. والأهم اللي درسني اللي هو دكتور ويليام جاش was his classmate, and William Gash is well known on the valve and the clinical echo around the world. فهي always telling me how دكتور القصوص يعني معروف beside معرفته في المنطقة، لكن his name is all over the world, across the world. فأنا يعني very privileged to have continue the same flow with Dr. Yusuf القصوص. يعني he's special to me.
أهلا وسهلا فيك.
كرمتني يا وائل، أنت الابن المبدع، الله يخليك وطول عمرك. شكرا.
أهلا وسهلا فيك يا باشا، وأهلا وسهلا بالجميع. وبنحب أكرر شكري للجي بي ام، الشركة الأردنية الدواء والإنتاج الأردنية المبدعين، ودائما داعمينا بكل الدعم. unrestricted support. عجبتني الكلمة هاي من الدكتور هادي وبعيدها وهم وافقوا على الموضوع هذا. أهلا وسهلا فيكم جميعا. راح نبلش. دكتور هادي أبو هنطش معك 15 minutes، راح نحكي عن التكنيك. just technique.
محمود enable me to share the screen please.
Okay, done.
I'm still disabled.
ثواني هسه بنظبطك ولا يهمك.
وانت عم بتظبطني، خليني ابلش احكي اني انا يعني I am privileged اني اكون مع كل الزملاء اللي موجودين معنا الحقيقه اليوم. and I'm also very thankful على ال continuing support unconditional without restriction من الجي بي ام. and on top of that الحقيقه انا باكد على وائل انه اخونا الكبير واستاذنا الدكتور يوسف القصوص يعني هو مش بس بايونير، الحقيقه هو اخ كبير لنا جميعا. we cannot at any point in our lives forget the pioneering job اللي عملها لكل الكارديولوجي في البلد. with that said هادي شكرا. هادي دائما كرمني يا هادي. تسلم. الله يكرمك حبيبي. هذا من تواضعك ابو طاهر. لا والله الله يطول عمرك حبيبي. Well, okay, let me start my talk now. I wanted also to thank Mahmoud for the full and the big effort which he did for establishing the Interventional Cardiovascular Innovation Group تحت مظلة جمعيتنا الأم، جمعية أطباء القلب الأردنية. وإن شاء الله the coming weeks and years will prove that it was one of the best ideas we did for interventional cardiology بالمملكة إن شاء الله. So my title left main PCI. I said tips and tips, not tips and tricks, on purpose as a matter of fact. So why left main? Why do we spend all of this time talking about it? You have to expect to find a left main lesion in 5 to 7 in non-dominant territory supplies 84% of the left ventricle. Big time. ما ضلش زيادة يعني. About it, that's why we take it seriously. When we look at and everything here has an implication. Distal location. And with the pre-dilatation and post-dilatation balloons, lithotripsy, etc. You have to expect multivessel disease in more than 70% of the cases, which means you have to coordinate work and effort with your cardiovascular surgeon as a heart team in order to know what's best for your patient. Remember that 90% of the distal left mains involve the proximal LAD. That has a big implication in our PCI because you have to remember that the main vessel is the left main towards the LAD. So 90% involving the LAD itself. The 2018 European Society of Cardiology put PCI compared to CABG as a class 1 indication only for syntax score 0 to 22 and 2A in syntax score 23 to 32. And when it's above 33, it's actually left for the surgeons to fix the left main. That's also arguable, but that's the way the guidelines are. So let me go to the technique. That's what Mahmoud wanted me to talk about. Ostial left main. It's not very common, but we encounter it. Most of the cases of ostial left main can be done with 6 French sheets by the radial approach using extra support guide. Some people might advocate using JL4, JL35 in order to not to deeply intubate. I'm not quite sure that's the best idea, but that's open for discussion. Avoid deep intubation by keeping the guide coaxial to the ostium of the left main, and definitely try to avoid deep intubation. You can use a floating wire. I'll talk about that in a second, in order to avoid the deep intubation and avoid damaging the ostium of the left main, which might be hazardous. You have to have a best added interrogative type of imaging or physiology. The best, in everybody's opinion, is IVUS for the left main, for the ostial left main. What's a floating wire? It was first described actually when doing the ostial right coronary artery. You have the guide here, you pull it back a little bit, you have the wire in the native right, and you put a wire which loops floating up into the ascending aorta from the cusp. What that does, when you put the stent in, this is your best marker where the ostium is, so you don't really have a lot of protrusion of the left main metal, the stent metal, into the cusp of the right coronary. Usually what you do, you put the floating wire in, you put the stent, you pull the stent a little bit back, and that wire will prevent it from coming further back, and you know you're covering the ostium then. Same thing goes when you do the left main bifurcation. You put an LAD wire, you put a circ wire, you pull a little bit the guide back, you put the floating wire in, and when you do, you put the stent and you inflate it slowly, you pull the system back, and that will be stopped by this floating wire, so that you will have a precise I hope that this is clear for my colleagues. Now, I said 70% plus of our left main lesions are bifurcation stents. And I think it goes without saying, if you want to start doing left main PCI, you have to master doing that bifurcating left main stenting. We know that if the side branch needs to be preserved, then simply look at this side branch and its likelihood of having an occlusion, okay? If the likelihood is very low, you do provisional. simple. You do provisional, and if you need to, you tap it by after that if you have to. Now, the side branch angulation and the side branch size compared to the main branch size will decide your technique. Why am I saying that? Look at the LAD and the circ. If you have an angle less than 70, culotte DK crush will do. And more than that, tap probably is your better bet. However, the DK crush can be still used here. Okay, we'll talk about that in a minute. So what is the tap technique? The tap technique, it stands for T-stenting with minimal protrusion. Remember, what you do, this is the left main, and this is the LAD, and this is the circ. In every bifurcating lesion, you need two wires. So you put wire left main LAD, another wire left main circ. And here for the tab, remember the tab, this classic tab, you start with PCI of the main branch. Here it's the left main towards the LAD. You pre-dilate it with a balloon. You put the stent in the left main towards the LAD. The wire is still there in your circumflex. You post-dilate the stent which you put in the main branch, which is the left main towards the LAD. Now the stent is already positioned in the left main towards the LAD. You have to rewire, so you bring after you pull the other wire, you rewire through the struts to the circ. You put the balloon in the circ. There is another balloon parked in the LAD towards the left main. You kiss them together in order to open the strut to allow the stent to go in. In the tap technique, all what you have to do is just minimally protrusion into the left main, so you avoid a lot of overlapping metal here. So just a couple, 3 struts maximum. And after you deploy the stent here, while the balloon is parked in the main artery, you do a kissing inflation of both branches. And you always finish in the left main with a proximal optimization technique, which is spot, in the main artery, which is here, the left main. And you have to stop before the carina, okay? You stop here. You don't come here, down here. You go before the carina. You always choose about 0.5 millimeter above the reference diameter, non-compliant balloon, and you inflate it to 20 and even more than that. And that's how the tap technique looks like when you finish the procedure. Okay, so I hope that's very helpful. How about culotte? I don't know how many colleagues of mine who are listening to me use culottes. It's not really commonly used, but it's a beautiful, beautiful idea when you think about it. Remember, in the tap technique, you PCI the main branch first, right? That's what we said. Now, excuse me. In the culotte, what you do, again, like any branch, bifurcating, you put the wire from the left main to the LAD, wire from the left main to the circ. Here, the difference from the tab, you do the PCI for the branch, which is the circ here. So you balloon the circ, you stent the circ, you pull the, usually a lot of us do that, you just pull the same balloon and post-dilate, but if you want to be safer, you bring a shorter balloon and post-dilate this, and avoiding the distal stent in order not to get the distal dissection. Now you already have a big protrusion of the stent, as you see here in this area, in the left main coronary artery at the ostium of the LAD. So what you do, you bring a wire through the struts of this stent from the left main to the LAD. The wire is sitting there for the circumflex towards the left main. And what you do, you balloon those struts to open them up in order to allow the new stent from the left main to the LAD to go in. So now you have the two stents, okay, sitting there, and you retain the wire position in both branches, and you kiss both branches with final kissing balloon. And again, in the left main especially, don't ever leave it without having proximal optimization technique. And that's short of the carina, and that's how it looks like at the end. Now, what is the major, sometimes, difficulty with the culotte? If you have a wider than 70-degree angle, which I showed to you before, between the LAD and the circ, what happens that sorry, excuse me for that. what happens, I keep losing my mouse, that there will be high restenosis. So if you have a wider angle between the LAD and the circ, avoid the culotte, please. You can use DK crush in that case. The discrepancy between the two vessel diameters, you can imagine, لأنك إذا لما تحط stent in the circumflex, let's assume the circumflex is only 3.0, okay? And the left main and the LAD are 3.5 or 4. What happens, this discrepancy will lead to incomplete stent opposition. But it's a beautiful, beautiful type of procedure to do if you master it, because it has less metal lying at the ostium of the branch, which is the circ here. Now the DK crush, which is very popular in the past several years, and because we have good data showing us that it has a better outcome compared to the other techniques, the difference between DK crush and the classic crush is relatively simple. You don't have 3 layers here covering the ostium of the circ, which is the branch here. And when you do classic crush, the problem is when you try to recross back to your branch, there's a failure of about 20 to 25% of not being able to, which will lead to poor outcome. While this is 100% in the DK crush, recrossing back to doing the final kissing. Now, the European Society in 2018, they were convinced enough to say that it's a class 2B to do DK crush for bifurcating left main stenting for our patients. Now, just in the PCI, the latest one, which was in this past July, the definition 2 trial came out. Just quickly, they randomized patients to either provisional or DK crush, but they chose bifurcating lesions, which are complex, not the simple lesions. So complex lesions, not simple lesions. What did this come out to? Definitely the 2-stent technique for bifurcation had better outcome in terms of target lesion failure, target vessel MI, and target lesion revascularization here in the blue bar, which is really wonderful. And the provisional has been the standard. But the provisional is wonderful for simple, straightforward lesions which do not have any involvement, the lesion itself of the branch with any major stenosis. However, the definition 2 trials كان عليها شوية أقاويل منها إنه 30% من lesions actually were left main lesions, but they did not give any subgroup analysis about those. وفي ناس بيعتقدوا يمكن لأنه 30% هدول we know that DK crush في left main distal has a better type of outcome compared to the crush technique and other techniques. Maybe that's what affected the positive outcome. With the provisional patients, actually 20% of them went on to have 2-stent techniques in order to bail them out. So would that apply also to non-left main? We don't know. And the other thing, the provisional has been also put in a bad situation. And in provisional, if you lose a branch, you can get a procedure of myocardial infarction, and the outcome would not look perfect. Now, so how do you do the DK crush? This is a distal left main, which is 1, 1, 1 lesion. You can appreciate that, 1, 1, 1 lesion. The thing about bifurcating left main يا جماعة ما حدا بيقدر يسمي هذا السيرك branch. Come on, this is another main artery. So you're talking about the 3 main arteries which you are actually trying to involve in your intervention. What do you do? Again, bifurcating, this is a femoral approach, but I actually do it radial, and you can do it very easily. Now, this is an extra support guide. You put 2 wires, one in the LAD and one in the circ. You put the balloon in, and you do your usual pre-dilatation, okay? Now, you have to do IVUS in order to guide yourself, especially knowing where your landing zone is in the LAD and the circ, and in order to study further the ostium of both vessels and know what the distal left main looks like, and in terms of matching the size. Now, when you do the pre-dilatation, then you put the stent in, right? The wire is parked in the left main towards the LAD. You protrude a little bit far into the main vessel, and you deploy the stent. Okay, so this is normal. That's what you do with like other stent techniques which we do. Now, the step 2 is that the balloon which is parked in the LAD, after you pull back the balloon which you inflated the stent with, you crush the stent, okay, with that balloon. So that's simple. And then you have to pull the original wire out of the circ and recross the proximal side branch, recrossing. You avoid the distal recrossing. You go proximal here in the area here, in order to do your first kissing. So this is the DK crush. There's a first kiss and there's another kiss. So this is the first kiss. You put the balloon in the LAD, which you have already there, which was parked. Now you have a wire which you introduce through the struts, and you put the balloon in and you do your first kissing, all right? So you finished with the first kissing. What you do, some people advocate pulling the wire out. Some people say it's not a big deal, so you can do it whatever you like. And then you put your stent into the left main towards the LAD now, okay? So now you have the stent here towards the LAD, the other stent which has been deployed, which has a protrusion in the main vessel. So what you do now, you do the first part. So this is the first part. So it's a DK crush with two part type of steps. You bring a shorter balloon, again 0.5 millimeter above the reference diameter which we used. Let's assume that was a 3.5 stent. Then you go to a 4.0 and you go to with NC balloon above 20 atmospheres easily. But you must have to stop before the carina. If you cross here, that's not a pot technique. That's called post-dilatation, okay? That's not a pot. So now, in order to rewire again to do your second kiss, you go actually from the proximal to the mid-side branch, okay? So that you can have easily access to the side branch stent and avoid distortion of the metal there. When you do the crossing, you put a balloon in the vessel, the circ, inflate it, a balloon in the LAD, inflated. So you do sequential first. This is very important. You do sequential dilatation first. Then you do your second kiss. So this is the second kiss with two balloons, very obvious, relatively simple to do. And the wires are already retained in both the branches. And the final thing of the DK crush, you do what? You do another part, okay? Another balloon, probably the same balloon you used the first time, in order to make sure you avoid having difficulty in accessing the wires for the branch mainly. And look at here, what did the operator do? The guide is pulled out there. If you are asking yourself why, that's to avoid what we call longitudinal deformity of the left main stent if it's sitting in the ostium or protruding a little bit. Please remember that, because longitudinal protrusion, longitudinal deformity of the stent can happen easily without you knowing about it. And then you get the final results, which is usually looking good, hopefully that you did a good job. And you do another IVUS, look at the distal left main, minimal stent area, 12.7 millimeters square. We know that 9.5 and above gives you a stenosis, which is really very low. Circ 8.5, minimal stent area above 7.5. Again, the LAD is the same. Beautiful result, and that's what we're looking for. You cannot get it really the way it looks here without an IVUS image. So what is my take on the left main PCI? This is my last slide. It's a complex PCI by definition. So don't take it easily. It's a complex PCI and needs a special expertise. Do not expect that you will become an expert in left main stenting if you do it once a month or once in every blue moon. And you have to have a good patient selection. Patients like this, especially in the bifurcating stent type of need, especially if you have multivessel disease, you must involve our colleague surgeons to talk about it like a heart team. IVUS should be the good medical practice standard of care for left main stenting. Not only me, everybody would say that everywhere you see it, in virtuals, meetings, everywhere, because we have data that IVUS of the left main leads to decreased mortality at 1 year. It's mortality, my friend, not only cardiovascular, mortality, and leads to better procedural outcomes. Most of the left main PCI cases, if you are a good radial man, can be done by radial approach. The only thing you cannot do with the radial approach actually is developing two stents together or having to do a rotablation of above 1.5 Baer, which we don't do frequently anyways. Get familiar and master the DK crush technique for the things I said, because it leads to better outcome. And do not try to perform your first DK crush in ischemic primary patients. بعض الإخوة الزملاء أحيانا بنسوا الدنيا يعني don't do the DK crush أول مرة بحياتك for a primary stimulus. Just avoid doing that. Simple ostial and shaft lift mains need simple approach, but IVUS is a must. There is no place, please remember that, of direct sending lift PCI. Please avoid doing it, even if it doesn't look calcified, because you don't know what's inside there, especially if you don't have an IVUS to help you out. Grip the lesion perfectly. That's very important. Use NC balloons, angioscalp balloons, and hopefully we will get the shockwave balloons in the future in order for us to prepare the lesions better when they are very calcified. Again, for the left main, like a lot of things we do in intervention, do not settle for good results. Good is not enough for the left main. You have to be close to perfect. Thank you very much, my colleagues. I hope إني ما طولت عليكم.
شكرا دكتور هادي، أبدعت. أخذت 7 دقائق زيادة بس أبدعت بالمحاضرة تبعتك والبرزنتيشن. احنا ما رح نسأل الأسئلة، نخليها بالكيسز. ممكن تعمل ستوب للشيرينج؟
I did. Okay. I did, my friend.
Okay, thank you. راح نبلش مع الدكتور دكتور أحمد. دكتور أحمد معنا؟
أيوة معك دكتور محمد.
إحنا عنا we have 6 cases، فبدنا نحاول نكون إحنا شوية يعني 10 minutes maximum تكون الحالة. وأنا عندي سؤال واحد للباناليست راح أحكي لكم إياه وبعدين بنكمل الحالة. تفضل يا دكتور أحمد.
السلام عليكم. Dear colleagues and professors, it's an honor to be with you today. My case is a 65 years old man. He's a smoker, he's hypertensive, diabetic, presented with chest pain with mild exertion and dyspnea class 3. ECG showed no ST changes. His troponin was negative and creatinine was 1.4. His ejection fraction was 30% with hypokinetic anterior and anterociptal and lateral walls. He had MPI was done before and showed 20% ischemia in the LV area, mainly at the anterior and lateral walls. He was on optimum medical treatment. So that was the coronary angio for him. So as we can see here, the left main is diffusely diseased and from the ostium till the distal, and the circ is also diseased from its ostium. There's tight lesion in the OM, and here a previous patent stent in the LED. So that was the right coronary artery. Here in the mid segment, it looks like a moderate lesion, and also there is a lesion before at the crux, the bifurcation distally. That also seems to be moderate lesion. So now the heart team discussion comes.
أنا ممكن بس أسأل الباناليست، إحنا عنا مين معنا؟ الدكتور وائل حسامي والدكتور رائد عقل معنا؟
نعم.
السؤال: what to do with this case? CABG, PCI, medical therapy, FFR, IVUS. تفضل يا دكتور وائل.
I mean, looking at this, I'm more in favor of CABG given his age, 65. Creatinine is not a factor in both. The study showed there is no mortality benefits between kidney failure between CABG and versus PCI in long term. The other one is low EF also. He might need support in both ways, either CABG or PCI. He has a good targets, I see, except the circ, iffy, but the circ is not a huge. He has a very large dominant artery, so I vote for CABG if that's possible. I see the lesion on the bifurcation of the RCA, but that could be addressed, but he would be better served by Lima or hybrid later on.
So you fair choice to go for surgery, CABG. Dr. Raed.
مساء الخير. I think this is an excellent case that stresses the idea of a heart team approach that Hadi alluded to. For one reason, I think this patient needs an IVUS is a must. I'm not convinced of the left main itself. So I think IVUS would prove the severity of the disease. The RCA is no question about that. The circumflex is no question. The idea, as Wael said, he will be better served with surgery unless the patient does not want to. If he is with the heart team approach, if it is explained to him and he still resisted the idea of CABG, I think IVUS and percutaneous revascularization is an acceptable option.
يعني انت the same first things to go for CABG, huh? But you need more data. You need FFR or IVUS to confirm the diagnosis, right? طيب دكتور سعيد.
دكتور محمود.
تفضل يا باشا.
يعني he's diabetic with left ventricular dysfunction, 65-year-old. I think CABG is more favorable option. طبعا زي ما قال رائد, the heart team decision is important, but it's how we approach the patient. يعني طبعا احنا الgatekeepers cardiologists. If we tell him it's very dangerous to go for CABG, he will opt for PCI, and most patients will opt for PCI. It depends how do you present our case.
Agree.
صحيح. Agree. طيب احنا
والله تلعب الليفت انجيو بليز, الليفت انجيو. وانتم بتحكوا بس الليفت كوروناري انجيو. ايوه. خليها تلعب بس while we are discussing. الله يخليك.
احنا خلصنا الدسكشن. احنا الان بدنا, لانه في عندنا حالات كثير مش حنخلص.
يلا.
فبدنا نحاول قدر الامكان انه نكون سريعين في الحالات ونعطي المسج. طيب دكتور هادي, في عندك شيء بدك تحكيه؟ انا لانه في شيء ولا نخليه للاخر بعد ما يحكي يكمل الحاله؟
لا, it looks like the colleagues in terms of patient profile and geographic profile and the data available are voting for CABG, which I will second them too.
Okay. Dr. Ahmed.
Yes. Regarding this patient, yes, please, Dr. Mahmoud.
الشعب بيحكي لك, بقول لك CABG. احكي لنا.
Yes, according to the guidelines, can we have the second slide? Yes, we have to calculate the syntax score. He is diabetic. If he is multi-vessel disease, yes, 3-vessel disease or more, yes, it is class 1 CABG and the PCI is contraindication. But here in this man, when we exclude the RCA lesions as significant lesions, here we get the syntax score of 22. So it's less than 20, or it was 21. Can we have the previous slide, Dr. Mahmoud? The previous slide.
Previous slide.
Yes, it was 21. When we excluded the RCA lesion, so the syntax score is 21. So here he is candidate for either PCI or CABG. But when we include the RCA lesions, it will be a multi-vessel disease. Can we have the next slide, please? So the syntax score will be 30. Can we have the next? So here, according to the guidelines, we are either between it's a left main coronary artery disease with a syntax score between 0 and 22. So here PCI and CABG are equal, or he is a multi-vessel 3-vessel disease and the score is above 22. So he is contraindicated for PCI, and the PCI will be only appropriate if the patient is completely refusing. So the next slide. So the decision was to exclude that RCA lesion with the FFR that showed it's not significant. It was done with intravenous adenosine. So here the left main, we were using the wire at that time. So we inserted the wire in the left main LAD, and it was 0.62. So it was highly significant at below 0.75, and this means the PCI here or the intervention will improve mortality. So it's indicated for survival. So here we have either PCI or CABG. So already we were there, and here is the guidelines. So it is now class 1, either PCI or CABG. This is according to the European revascularization guidelines. So next please.
قبل ما نروح للنكست، دكتور رائد، دكتور وائل حسامي والباشا دكتور هادي، any idea do you agree with the دكتور أحمد؟
يعني المشكلة
طلع السنتك سكور طلع either CABG or PCI and he decided to do PCI.
المشكلة إنه في ostial LED, so it's difficult to know if this is the FFR related to the ostial LED or to the left main, more likely to be related to the LED, and he has a complex left circ, and still I'm puzzled about the RCA a little bit because definitely has a wall motion abnormality was seen on the echo. His ejection fraction is 30%, and so three vessel disease, diabetic زي الباشا ما حكى, and on long term I think CABG would be better based on that.
Still CABG. الباشا still CABG, right?
Better option definitely CABG.
Better options. دكتور رائد عقل.
I think using the syntax score only, we know it is based on anatomy. But if you use syntax 2, where you add LV function, presence of comorbidities, I think this patient will go very directly to CABG. I think syntax score, number 1, is very unfair, though the studies were done on that, but I think it's very unfair in the low ejection fraction group. So I think I will still go for CABG if the patient is agreeable.
Dr. Ahmed, you don't convince
still the guidelines are against the syntax score 2 also. So the guidelines only for syntax score 1 because it is the validated one.
May I say something, Dr.
Yes. So it's either CABG or PCI. Yes, this is.
I think that the thinking which Dr. Ahmed is going through, in my opinion, is very educational. So he used the tools to make a multi-vessel disease look like a two-vessel disease with a left main plus minus, with a left main which he interrogated with an FFR, and it made it look worse. Now, the only thing about it, like what Dr. Weil said, I would not say, did you do the FFR with LAD left main and circ left main, or just left main LAD, Dr. Ahmed?
Yeah, it was done for the circ also. But as you know, here we have a distal tight lesion in the circ. Yes. So it would affect the result, but it was also significant.
You can do a pullback, You can do a pullback.
Here was in the left main LAD. Okay. Because when you have a distal tight lesion, that tight lesion can increase the pressure distally, so you will have a non-significant reading while it is a significant lesion. But this is only for the circ. The LAD, we consider the ostial LAD is the same as the distal left main, because here it is the same plaque that extending from the distal left main to the ostial LAD. We cannot differentiate and say it's only ostial and the left main is okay. No, it is diffusely disease from the ostium of the left main to the ostium of the LAD.
Well, for the sake of time, I think you have to go.
Dr. Ahmed.
So the decision was to go for the DK crush technique. Here with the cannulation with the guiding catheter, the pressure was damping. So that was a more confirmation of the significance of the left main disease. So here we went for the DK crush technique with disengagement of the guiding catheter, not to dampen the pressure. The technique is to put the circumflex stent and to put a balloon in the left main LAD, and then to inflate the stent covering both lesions. Of course, the preparation of both lesions was done first. So we stented the left circumflex and putting the stent in the left main LAD. This is a very important step, because if you just stent the circ and losing the main branch balloon, you can protrude too much inside the left main, and then it becomes too a culotte. You cannot pass the balloon, so you have to recross from the struts again, and then it will be like a mini culotte technique. So after stenting, we crush the previous slide, please, Dr. Mahmoud. Yes. So here we remove the wire and the balloon of the circ, as in the left video, and then to crush the circ stent with the main balloon in the left main LAD. Next. Then to recross the wire and open the struts with the balloon, and this is our routine, and then to go for a smaller NC balloon with the balloon inside the left main LAD, and do the first kiss as it is in the right video. After the right kiss, after the first kiss, we stent the left main LAD. Here we have to cover the ostium of the left main, so we need to have the LAO projection, so not to miss the ostium. Next, please. And deployment of the left main stent, and then recrossing again. Here, the recrossing is better to be done through the middle struts, middle of the circumflex, not the distal as the tap technique. Next, please. While putting the balloon inside the LAD, we were trying to cross the left circumflex and the balloon was not crossing. Here, we have to do first just repositioning the guiding catheter to make it more coaxial, and then try to pass the balloon. If it didn't pass, we have to do the first pot before trying to pass the balloon again. But here, while adjusting the guiding catheter, the balloon crossed easily. So next, please, Mahmoud. Here is adjusting the guiding catheter coaxial, and then passing the balloon. It passed easily from the left panel, and then the right, we did the second kiss. Next, please. And then after that, we do the pot, which is the mandatory step in DK crush technique or in bifurcation two stenting strategies. And then after that, we have to flare the left main ostium with the bigger balloon that was used. And as Dr. Hadi said, it has to be 0.5 to 1 millimeter above the stent size. Here we were using a 4 millimeter stent, and then post-dilated with a 4.5 NC balloon. Next, please, Dr. Mahmoud. And that was the final result.
شكرا لك دكتور أحمد. Panelist.
Very well done. But just have questions to the panelist and to Dr. Hadi and all of you. I mean, whoever want to answer. When do you use hemodynamic support when you see this like kind of low EF? How do you decide about it?
I think, well, that's a beautiful question. I think what he did is beautiful. I mean, you cannot argue about success, and geographically, it looks beautiful, as you said. I think this is a good case to have some support. Unfortunately, we don't have Impella here. The only kind of support, which is not really the best support in the world, is a balloon pump. But we don't have Impella. That would have, in my opinion, this is an Impella case. Because God forbid if something happens, this patient might crash on the table. So I agree with you. Yeah, go ahead.
Dr. Hadi, and I support what you say. In the Blue Cross Blue Shield Michigan Collaborative Registry, PCI was performed with mechanical support in Impella is currently recommended for high-risk left main patients with depressed ejection fraction, 35, below 35. So this case is definitely a good candidate for a support, whatever support you use.
Dr. Wael, other technique other than DK crush للحالة هذه بالتحديد?
You know, given this complexity of this left main, I am with the DK technique for long term, and I agree with that. It's very complex bifurcation lesion. So That's what I think. What do you think,
I agree with Wael and Hadi. I think this is a two-stent technique from the start, because in an ejection fraction of 20%, every branch does count, even when it is 2.5 or 3.0. So we need to preserve as much as possible to give him the best benefit. I would just reiterate what Hadi has said about the value of IVUS in these cases, much better than a physiological assessment with all of its withdraw points. So I would still, this is an example case, a classic case for IVUS. The results are excellent. Congratulations, Dr. Ahmed. Very well done. You did it without even hemodynamic support. But I think sometimes things might go wrong. So maybe for next cases, you need to consider a hemodynamic support.
Dr. Mahmoud, just can I show the audience one thing, if you can? There is a very nice, well done app. It's called Bifurcate, and this is by Mount Sinai, and basically it's giving you step approach for, I don't know if you see it or not, but it's called Bifurcate from Mount Sinai. It is for left main, and it will show you step-by-step technique, not just the technique and when to use this technique or that technique, and also when you go simple, when you go difficult on these, and also even we'll show you the other side branches in the LED and diag and so on. I think having such tool and reviewing the case before you start, such a tool will be very helpful because so many steps, and we cannot remember every single step in general if you want to do multiple ways, unless you want to adhere to just one technique all the time.
I agree.
يلا شكرا لك دكتور نزار. دكتور نزار معنا؟
نعم.
محضر كويس، كل شيء جاهز؟
إن شاء الله.
طيب ماشي. طيب. This is the second case. تفضل دكتور نزار.
شكرا بالبداية على الانvitation. We're bringing you a case of a 42-year-old man, previously fit and well. He was a heavy smoker, and he presented to our emergency department with 1 hour duration of severe cardiac sounding chest pain associated with shortness of breath and sweating. His ECG was showing a massive anterolateral STEMI. He was transferred to the cath lab for primary PCI. We'll show you his first diagnostics. This is the initial diagnostic of the right, and you can appreciate just mild diffuse disease there. Didn't think there was anything significant. Before we move on to the left system, and to see this massive thrombus at the distal left main involving the ostial of the left circ, and you can also appreciate the absence of the LAD, which was totally occluded.
السؤال التقليدي للباناليست: CABG, PCI, medical therapy, FFR, IVUS, anything else?
I just go with directly to PCI. This is an acute STEMI. I would not wait for anything.
All of you agree this is acute coronary syndrome, anterior MI, PCI. Agree with you. Dr. Nizar, Campbell?
Yeah, definitely. We thought this is a life-saving emergency. There's no point in doing anything. We got our first wire in the left circ, and we've done the first balloon dilatation just to try to open up at least a single vessel with the circ. Then we managed to get the wire into the LAD, which you can see it going through. And then we've done the dilatation of the LAD. Now we can start to having some flow, and the patient becomes more hemodynamically stable. And we can appreciate the distal left main disease and the LAD. This is the stent going from the LAD into the distal left main. The stent was inflated, and you can appreciate that we had no flow in the left circumflex. We couldn't pass a new wire to the left circ, so we've done a pot into in the left main stent. Before going in with a new wire into the left circ, managed to get a balloon, and we've done a kissing balloon into the left circ. And it's not this one yet. So we managed to get a new wire. This is the new wire going into the left circ. We pulled the first wire out, which was under the stents layer. And then we got small balloon then we've done the kissing balloon between the left circ and the LAD into the left main. This balloon has restored flow into the left circ and the LAD. The patient become more stable, the ST depression, the ST elevation has gone down, and the patient became more stable. At this stage, we decided that, well, we've had enough, he had enough, and we've given him 40 milligrams of agrostat intracoronary, which is our usual standard in ST elevation MIs. And then we thought he's stable enough. We'd appreciate that the ostial of the circ wasn't good enough. And we thought we'll stop here and then we'll bring him back 48 hours later to try to optimize our results, fix the severe lesion in the mid-LAD and optimize the LAD left main stents.
ثواني دكتور نزار. Do you agree مع الدكتور نزار إنه postponed ل 48 hours with agrostat and heparin and then he come back to the cath lab, or he should continue? What do you think?
I would continue. Optimize. Optimize.
Dr. Raed.
So this is a middle of the night case. I was called at 1 a.m. This is what we learned. Always leave the cath lab clean, not dirty. So I would do what Nizar has done. I would, the man is alive and his STs are down. I'll give him a breath of air, give him anticoagulation, bring him the next day in the daytime, and do maximum, intervention for the left main, left circ, do whatever is needed. Sometimes you will be surprised that the ostium circ is really a clot. It's not a lesion, and it will dissolve, and you will be surprised what you can get angiographically the next day. The only thing I would do different, I will do PUT for the left main stent before I leave the cath lab.
Dr. Hadi.
I agree, right? I mean, a PUT will be essential in this case. When you go back, Nizar, to your initial angiogram, if you can quickly, that will be all right. But the ostium of the circ at that time was not of any concern, I thought, right? I mean, the first picture where you had the big filling defect sitting in the distal left main, I don't think the circ ostium looked bad or anything. So okay. I would second the idea. I mean, Wael wants to make sure that he completes the job. I mean, that's a good thought too. I probably would, if I want to do anything for this ostial circ, I will FFR it to make sure it is significant to begin with.
It's clear.
Otherwise, I will just leave it.
Any ideas من speakers or panelists? إضافة قصيرة. Any things you add? طيب.
والله
نزار. يا باشا. تفضل.
أنا مع نزار إنه I would wait for 48 hours. Hit and run. بعدين if it's 3 a.m. in the morning زي ما حكى رائد يعني we don't have all the support حواليه. He did a good job and hit and run. ده بعد 48 ساعة.
دكتور وائل حسامي 5 على البطل. كمل يا دكتور نزار.
My concern, first of all, his circ went down at some point when he stented the LAD. And my concern, there is little chance the circ might go down again. And the circ was open at the beginning. And if that goes down again, you have already damage to the LAD anterior wall, then you're adding another damage to the circ, and then he might get in 11 hours or so cardiogenic shock from his LAD and then sink down. That's the whole idea. I mean, it's not like some black and white, you have to do it, but thinking ahead, what's going to happen to the patient. And I would not sleep in the 4 in the morning, just leaving this and go.
Okay, كمل دكتور نزار.
Well, the idea is that we thought the circ has gone, as Dr. Hadi said, the ostial circ wasn't bad initially, and we thought this was a big thrombus which has went into the circ territory, and that's why it was occluded. So we've ballooned it, we've given agrostat intracoronary, and we continued with agrostat IVI and heparin, and thought that would save us the time. The patient is now stable. He's got no chest pain, no ST elevation, and we could work later on when this clot has dissolved and then we can reassess the vessels in a better way, and then go again for further PCI should that be needed. So this is the recap after 48 hours, and you can appreciate that the left circ still looks ugly. The left main LAD stent looks fine. And the severe lesion in the distal LAD or mid-distal LAD was still there. So we went in with two wires, one to the LAD and one to the circ. So this is the LAD wire. We've put the stent in the mid-LAD, as you can appreciate now, and this has been fixed. We tried to wire the left circ, and we couldn't. So we've done the pot now. So we've potted the left main, and then we went in with another wire into the LAD at the circ. We've done the kissing balloon, as you could appreciate here. And still, we were unhappy with the left circumflex result. We thought the ostium wasn't good enough. Looking at the angle, which is almost 90 degrees, so we thought we could just have a combination of a mini crush or just a 90 degrees tap T-stenting. So this is a 3-5 drug-eluting stent into the left circumflex, just protruding 1 or 2 struts into the left main, and there is a balloon in the left main ready to crush it. So this is the inflation of the stent in the left circ. And then this is the kissing of both the LAD and the left circumflex. Appreciate here that the results are fairly fine. We know that there is a good data to suggest that using one balloon, both balloons were in the left main and they post-dilated the stent, although there is data that you could just pot it again with a single balloon in the left main, although this was short and we didn't have a shorter balloon to pot the left main without involving the carina of both the LAD and the circ. So we're happy with the results. The LAD was fine, so was the left main, left circ and LAD.
أبدعت يا دكتور يا حكيم شخشير، أبدعت بالحالة. في أسئلة عندكم على الحالة هالباناليست؟
Yes, I would start with Nizar. This is an excellent job, excellent life-saving. I have a question for you. These are the kind of patients, young people came with cardiogenic shock, maybe putting a balloon pump, though the data is not very strong, to support him for the next 48 hours before the second session. I would have done that myself. That's number one. Number two, would you think that covering the whole left main with a stent is an option now that you could have done? Because I'm not very happy with mid-left main stenting, even the ostium and the proximal, and without an IVUS, you cannot tell what's happening. That's the only thing. Otherwise, it's an excellent, excellent life-saving. Good job.
I think, thank you. I think for the balloon pump, we tend to depend, there is no data to tell us that balloon pump would improve the mortality or anything like that with the trial which was done. So we depend on the patient hemodynamics. If I had a patient who is hypotensive, needing adrenaline, noradrenaline, I would definitely put a balloon pump for him. If the patient is having a blood pressure of 140/80 with no support at all, then I'll be more comfortable in leaving him without it. As far as the left main, if I have a short left main, I always tend to cover it all the way up to the ostium. In this case, I thought it's a long left main. I don't want to add further metal struts into the ostium. So we decided not to. We had a discussion next day when we had the surgeon with us and whether we should put another stent extending from the mid-left main into the ostium, and we decided not to.
طيب الله يعطيك العافية، أبدعت فيها. سؤال لك يا دكتور نزار. بوت، أعطينا الفاليو اوف بوت. يعني في عندنا احنا فيلوز موجودين معنا، يعني أعطينا الفاليو اوف بوت. يعني أنت بالحالة الأولى الواير كان موجود وقن راحت السيركمفلكس and you did pot, right? وبعديها فتح عندك اعطينا الفاليو اوف بوت.
هلا the main thing البوت في عندنا شغلتين. واحدة الشغلة الأساسية إنه أنا لما بدي أرجع أفوت في وايرز ثانية I need to make sure إنه I'm not going behind the stent struts. فلما تكون الستنت موجودة عندك بالليفت مين أو بأي برانش بتعمل له bifurcation وبتيجي بدك تعمل ريكروسنج بالوايرز وتجيب واير جديد، إذا أنت مش عامل بوت الواير تبعك ممكن يفوت underneath the stent struts من وراها بين الستنت وبين الفيسل وتيجي تفوت البالون you disrupt the stent. فالبوت الشيء الأولي الأساسي تبعه إنه أنت you make sure إنه your stent is opposed to the wall. الشغلة الثانية اللي بمثل هيك حالات إنه إحنا لما بدك تيجي تفوت على سايد برانش ممكن إنه الستراتس ما تكون موسعة بشكل جيد اللي تقدر تفوت فيها بواير وبالون. فأنت لما بتعمل
so you will change the carina, right? You will change the carina.
Exactly.
تعمل new carina.
Yes.
You may
facilitate إنه recrossing with the wire and the balloon.
طيب من السبيكرز في حدا حابب يعلق قبل هاي أنهينا الحالة هذه؟ يعني حدا حابب تعليق من السبيكر؟ دكتور أحمد، دكتور إياد، دكتور كرمي. هو
سؤال I missed whether he did thrombectomy in the beginning. There was a huge clot burden, and you know in the US I'm not sure about the European guidelines and practice in Jordan whether they support injecting 2B3A locally in the clot.
We don't routinely do thrombectomy, and again this was evidence-based that it didn't improve mortality or morbidity for these patients. Intracoronary 2B3A, this is the standard practice that we do, and we give the initial dose intracoronary, and then we continue with the infusion as well as the heparin infusion intravenously later on for the next 24 hours.
طيب شكرا لك دكتور نزار.
احنا clot burden probably it's good to do manual thrombectomy just to avoid shift of or migration of these thrombi.
دكتور احمد كامل، احنا حنبلش بالحاله الثانيه.
سامعيني كده؟ صوتي مسموع؟
سامعينك، بس انا بدي الفت انتباهكم. انا بسال اكثر للباناليست. السبيكرز عندنا كتار احنا اليوم، فتركيزي على الباناليست فقط، اما اللي بحب يشارك من السبيكرز ما في معنى بمختصر، لانه الحالات عندنا كثير اليوم بدنا نحاول، يعني الوقت عندنا ضيق نوعا ما. فتفضل يا دكتور احمد.
Good evening. I'm very happy and pleased to be with you today in this elegant meeting. I will go fast. This is my case. Left main PCI, multivessel PCI when CABG is impossible, or when there is no way for CABG. It's a patient who is 75 years old, engineer, diabetic on oral therapy, hypertensive, ex-smoker with positive family history of coronary artery disease. He had an ACS 7 years back. Did an angio with no available data, no CDs, no videos, no reports. But he says that he's using aspirin, statins, and clopidogrel. He presented with chest pain and transient ST segment elevation in the pericardial leads. Actually, he was on clopidogrel, so he was shifted to ticagrelor, and angio was done through the right radial axis. So can we go to the angio, Dr. Mahmoud? Can just, yes, this is the left system. As you can see, this is the right radial angio. As you can see, there is a very ugly lesion, very ugly calcific, maybe thrombus containing hazy in the proximal part or the ostium of the LAD, as you can see. The distal part of the LAD, as you can see, it's very diseased, severely diseased. Actually, this is his right coronary artery in the left-hand side. As you can see, the distal part of the right coronary artery is severely diseased and beaded. So we have distal left main is shown here So I would like to ask the panelists and the speakers. Yes, this is what I try to ask.
Yes. How should I treat CABG?
75. I just revised the patient data. He's 75, diabetic, CABG, PCI, medical therapy, anything. Can we vote or?
Dr. Wael.
Okay. Well, first, welcome from Egypt.
Thank you,
excellent
sir.
case to present. I'm glad I'm not. I wasn't attending on call that night.
Yes, actually, I was trying my best to avoid this patient. Actually, he's the grandfather of one of my daughter's friends in school. At school, my daughter's colleague. She's 7, and this man is her grandfather of her colleague. So I was trying my best to run away, actually.
So that puts more pressure on you. From a CABG point of view, no, I don't think this is a candidate. We had diffuse disease. There's no targets for surgeons, at least I'm talking on their behalf now, but I'm not seeing any good targets for them.
Sure.
So is medical option is an option, only option here? No, it is not, because the man is symptomatic. He has close to a clot, left main LAD. So we need to do something. So it is a percutaneous intervention, but it will be a complex case.
So Dr. Mahmoud, can we ask another question for the panelists and the audience and the
yes,
speakers?
You can ask.
Yes, if you allow me, of course.
Stage is yours.
Dr. Raed, what's your plan in this case? Which lesion will you start with? Which lesion to attack? Which lesion to tackle?
Okay.
This is a very important question.
محمود هم بيحكوا حط الانجيو حط الانجيو
شكرا دكتور هادي شكرا.
شكرا احمد حبيبي. It's good to see you دائما.
Thank you, sir. Thank you.
So if we are looking at anatomically, which is the culprit artery? I think clinically, if the EKG, Dr. Ahmed بيساعدنا فيه.
ST elevation, 5 millimeters, 5 small millimeters in the epicardial leads. V1 to V6, lead 1 AVL, transient. It was transient. Just half an hour after receiving ticagrelor, it was gone.
Well, I guess that's enough for me that the man needs a pan-revascularization, but my target in the first session is to revascularize the left main LAD, left circ as much as I can.
True.
From what I see here, that the left main ostial proximal LAD with prox mid circ should be the first target to start with. Sure. And then based on the results, I will decide further intervention in the same arteries or in other areas.
Yes, sure. تعارض خاطر دكتور رائد، ده تعارض خاطر. هنشوف في the next.
ممكن احكي شيء انا دكتور احمد تسمح لي؟
تفضل يا فندم.
رجعنا الليفت سيستم. هلا الليفت سيستم هنا in the PA codal review, the left main does not seem to have a critical lesion. This is just tapering of the left main, just tapered down.
صحيح.
And you have what appears to be a significant lesion in the proximal LAD.
Sure.
Plus minus calcification, haziness. You have it. The diagnosis of this patient is by definition a high risk non-STEMI. I mean, this is a high risk non-STEMI because of transient ST elevation.
Sure.
When you look at what you're seeing here, he's not a good CABG candidate, and with all my due respect, he's not a good PCI candidate either.
Sure. Yes.
We have to be fair to the surgeons and fair to ourselves.
Sure.
If you open this proximal LAD and you look, the LAD segment, which is defined as the mid LAD, it's right.
Yes, sure.
What's before that is the proximal, and this is here coming down. This is the distal LAD. So what is the benefit you're going to get other than getting more blood to some septal branches? I would say I would go to the maximum medical therapy in this patient because I'm not quite sure that either PCI or CABG will be of a great help.
يعني دكتور هادي medical therapy. Anyone agree with Dr. Hadi?
I would vote with Raed about PCI, but I would keep it simple. The reason I think there is good diagonal branch, you might just increase the flow to that diagonal branch beside the mid LED. And I would say he has a good ostial circ. Despite that, I would wire both, but I would try just to stent that proximal to mid LED and get out of here.
طوارئ خواطر برضه دكتور وائل.
طوارئ خواطر.
تفضل كمل يا دكتور احمد.
Actually, this patient, his brother, his elder brother, had CABG with one of the most talented cardiac surgeons in Egypt, and he ended with a recent sternum and wound infection. So the family had a very bad experience with CABG. Actually, I told them that I cannot guarantee that I will do a good PCI procedure for the patient, and I asked his children or his sons to seek for a surgeon's advice. So in the same day, we had the surgeon in the cath lab. He saw the angio, and he said, just as you all agreed, the distal targets are very bad, and he would do end arterectomy and the venous patch and the lima and the targets and it will be a very heroic operation, and at the end he will not benefit so much. So I was pushed to do the PCI, but actually, for the sake of time, I tried first to predilate the LCX, the distal LCX, and stented the left PDA, if we can say it, if you can call it a left PDA or a big OM. Just did it first. It's the downstream lesions. Then I tried to balloon dilate the distal or the mid part of the LED, as Dr. Hadi said, this very distal part. Actually, I tried to open it with some balloons, as you can see here in the left-hand side. This is wire, the LED in the left-hand side. I just ballooned this distal part of the LED, so it will appear more elegant, if I can say this word. Then I had the two wires, one the LCX and one the LED, trying first to predilate the ostium of the LED, this heavily calcific thrombus-containing ugly lesion. Then I took a stent. Actually, it was impossible to land the stent just at the ostium of the LED. Dr. Hadi said that the LED is the left main has it's not significantly diseased. Yes, I agree, but it was impossible to land the stent just in the LED ostium. I'm not sure if the plaque extending to the left main or not. Probably it's extending. If you can see here in this right-hand side in this video, Dr. Hadi, the left main is tapering. So I think the plaque was extending to the left main. So I tried to be as safe as possible. I landed the stent just at the mid part of the left main, just sparing the ostium. As you can see, this was a 4.0 by 38 millimeter stent, Teromo Altimaster stent. Just in this views, I'm just trying to put it in the proper place, covering the distal and the proximal parts of the plaque, as you can see here. Many projections, the left cranial, the right cranial, everything, just to make sure I am covering from healthy to healthy. Actually, there is nothing healthy, but as much as I can, yeah.
Dr. Ahmed, just a quick question. What was in your mind, just to do provisional here and just get out here?
Actually, I want to keep it simple. It's very complex. By the way, the coronary anatomy is very complex, so I preferred not to complicate it more. Actually, so I tried just to secure, just stent the LCX distal lesion first, downstream lesion, and to keep the wire in the LCX, wire the LED, do the distal part with a balloon, just a balloon dilatation, then to stent the ostium of the LED with the left main, keeping the wire in the LCX just in case anything happens. This is 7 French actually. I did the angio radial axis, 6 French radial. Actually don't have in Egypt the slender 7 and 6 French sheath by Teromo, so I used the femoral axis. This is the other case. In the second day, I did the angio in one day, the PCI in the next day after surgeon's discussion. This is 7 French right femoral axis, 2 wires. This is then this is pot. Actually, I did post-dilatation in the LED with a 4.0 millimeter 4x8 millimeter balloon in the LED and 4.5 by 8 in the left main. So I did pot in the left main and post-dilatation in the LED 4.0 and 4.5. Mahmoud, can you just shift to the So this is how it appears. The cranial in the right hand side and the caudal, the spider view in the left hand side. As you can appreciate, it looks fine. Actually, it's not that good, but I think it's better than what I start with. So this is
Dr. Ahmed.
شكرا.
This is the final
Yes,
review, right?
Yes, sir.
طيب.
Very well done.
الباناليست دكتور وائل.
يعني I think angiographically was very well done, and زي ما رائد حكى قبل هيك اللي هو وهادي the IVUS would be يعني for long term would be an ideal things to do. I'm not sure if it's available or not.
Actually, it's available in Egypt, but in that hospital, in this particular hospital, it was not available. But yes. I used the 4.0 and 4.5 non-compliant in the left main, so I think IVUS will not show me. If I have used the IVUS, this is the maximum I think we have in the cath lab, 4 millimeter stent and 4.5 millimeters non-compliant. This is the maximum we have.
Yeah, I think the result is excellent, but just من ناحية what you do ideally, if all tools available, I would definitely use the IVUS. But the result was excellent, and I think that's what we need to keep it simple, and that's a great way. By the way, the background تبعك very nice. I wish
it's a virtual background. You can just download it from the internet.
أبدعت دكتور أحمد.
Thank you.
الآن راح نبلش مع الدكتور الكرمي. دكتور إياد أنا حطيتك آخر حالة حسب طلبك.
ممتاز. الله يسعدك.
طيب الكرمي.
خلينا نشوف شعاراتك.
يعني في الشعارات راحوا من زمان.
تفضل يا عمرو.
مساء الخير جميعا. This is a case for discussion. This is a 60-year-old gentleman who's a university lecturer. He's got well-controlled diabetes, well-controlled hypertension, and he never smoked. He had a history of previous PCIs to the LAD and to the codominant circumflex and to his small PDA, right PDA, 6-7 years ago. And then he started to complain of angina, was evaluated in another center. He had almost normal test at that time, but subsequently went for a coronary angiogram. I don't have the diagnostic coronary angiogram, but the left main was very short. There is the distal left main mide plaque with the moderate plaque disease in the osseal circumflex with severe osseal LAD disease and severe RCA disease. And he was offered surgery, was seen by two surgeons, and he had there's a lot of multiple views, but we can't actually appreciate the anatomy of the distal left main and osseal LAD. And however, he had a lot of, he's a private university lecturer. He had a lot of issues about going to surgery because taking post-surgical sick leave for 6 weeks, he may lose his job. He was adamant to have a PCI and not to have a CABG.
خلينا ناخذ رأي الباناليست دكتور عمرو. دكتور وائل, دكتور رائد, what do you think?
I think maybe the CABG would be difficult in this case because I think his bridge were burned. If you look at the stents all the way to mid to distal LAD, so that would not be an easy way to do CABG for this patient to start with. And yes, he has, just only something that I would just focus on the osteal LAD and try to be simple again on this. But he has a very huge left circ, which is feeding most of the heart, I would say, maybe 60% of his heart. So maybe high-risk PCI.
Dr. Raed?
Completely, I support Wael with the choice that this is a percutaneous intervention for multiple reasons. Of course, the first of which the patient doesn't want to. But I would here disagree maybe with Amr saying that the left main is okay. I think the distal left main has significant, more than 50% disease. Have you done if an IVUS would be done? But beyond the point, is not a CABG candidate for what Wael said. There's a full stent jacket to the mid-distal LAD. The lesion appears to be simple. He is a good protoplasm for a complex percutaneous intervention, left main, LAD, left circ, provisional. That's my way of thinking about this man.
طيب دكتور كرمي تفضل كمل.
So we elected to go for PCI, but obviously you've already highlighted that the osteal LAD is the main target, and we decided to go for a simple provisional stenting to start with. I offered the IVUS, was not approved by his private insurance company, and the patient basically refused to pay for it. I was really keen to have an IVUS on board. So we went for a simple strategy with 6.5 sheetless guide through the radial artery, EBU 3.5, and first pre-dilated the osteal LAD, then went straight for stenting. Because of the left main is so short, I just decided to cover the whole left main because I didn't want to get into the sizing issues. So this is the first slide on the left is actually the ballooning, and then the stent basically deployment, or next slide. That's just positioning of the stent. I don't use the floating wire Dr. Hadi said before. I usually put a kink at the end of my wire and push it. That will usually push the guide back, and I get more control of my guide. Obviously, this is just the positioning, and then the deployment. Next slide. So after we deployed the stent, there was a plaque shift to the circumflex artery. Basically, I can't see that slide. Maybe the one before. Just like the plaque shift is about 50% of the circumflex was compromised. So rewired the circ, just put a balloon in to open the struts, and that's basically going for for a stent, a mini crush, whatever you want to call it. It's not anything now, it's just saving the circumflex. And basically minimal struts protruding to the left main with a balloon in, and then pulled both balloons in, back, just inflated both balloons. Next slide. This is just for the dilatation and flaring the ostium, and the last one is the final results. That's was done about 19 months ago. Now he's still working, still asymptomatic, and basically what he was aiming for is he has a
دكتور عمرو احكي لنا شو التكنيك اللي عملته هون عندنا تاب تكنيك؟
No, it's a provisional stenting, but you cannot call it tab because I didn't pre-dilate the circumflex to start with. This is a provisional, but the stent deployment, the ostia of the circ is so difficult. So what I've done is I actually partially inflated the balloon in the LAD, which is a 3.5 balloon, and pulled the stent till it's actually in the circumflex, till it hit my balloon and started getting resistance. And that's when I deployed the stent, then pushed it back into the circumflex, inflated the balloon in the left main to fully, to 16 or 18 bars, and then did the dilatation or the kissing. So probably amplified tab.
It's like a reverse mini crash, right?
Yeah, or reverse mini crash, or
The only thing is too much metals on that. Just I have a question before the panelists say anything. Did you overlap the stent with the stent on the LED, or there was a gap? I cannot see on my computer well, so can you comment on that?
It is overlapped, but there are two stents over that diagonal, which the area you see. And it's basically 7 years old stents. I'm not sure what type of stents they were. The stents we use in much radiology.
Can I just comment on a couple of things? When you do provisional, I think that's something which we have to make clear, I think, for all of us. When you do provisional and you have to convert to two-stent technique, what you did is actually a classic TAP technique. That's what it is, by definition. So what you did the provisional. You did the provisional. You had a compromise of the branch. You put a stent in. You kissed them. That's a TAP technique. So it doesn't have any other terminology in my book. It looks like it's just a TAP. Actually, in the left main, and that's a message which is important. In the left main, when you do provisional and you get in trouble with the branch, your best bet either a TAP or a culotte. I mean, that's how you get out of trouble in those cases. So that's important to remember. The other thing which I think the IVUS issue here is so important in this country. I think we cannot just keep going like this in Jordan. Insurance companies down us not doing it while they are covering other silly things which I'm not going to name here, which are more expensive than an IVUS catheter. I think we cannot go like, we have to find a way to have the IVUS has to be, as I said, for good medical practice, part of left main PCI, period. In my opinion, this is one. And the other thing, Amor, and I would encourage everybody, including you, my friend, don't forget the pot. I mean, pot has to be done. This is an important thing to do, especially in the left main. In all bifurcations, you have to. But in the left main, please don't finish without a pot. I mean, the pot is so important.
There was a pot, but the slide is missing. But there is a pot.
Okay. But thank you. Good job. Good job.
يعني بنهاية المطاف, this is TAP technique most likely, right?
Yes. It is TAP.
I mean, with missing two steps, yes, but it is a TAP by definition.
شكرا لك دكتور الكرمي, أبدعت. إياد.
Yeah, thanks.
أنا حسب رغبتك حطيتك, طلبت رقم 4 حطيتك آخر واحد.
Thanks والله, لأنه بتعرف زي ما تفضلت تغيرت, I had to prepare a little bit, just I didn't remember.
بس بدي أسأل سؤال أنا, لما الواحد بكتب papers بكتب رقم 1 بكون أعلى إشي, وآخر واحد كمان له دور ولا لا؟ يعني senior. بعد رقم 1 بيجي آخر واحد بالبيبرز لما نكتبها, أجري ولا لا؟ مش في له مهمة آخر اسم؟
أكيد.
مش معي يا دكتور.
not senior guy.
تفضل يا تفضل.
Yeah, thank you. Thanks for accommodating me, last speaker. So, or before the last. So, يعطيكم العافية كلكم. Thanks for this invitation. So, this is a. Can you go next, please? Do I have control over the slides or do?
لا, هذا أنا اللي عامل كنترول والله كامل أنا. أنا متحكم في كل شيء والله يا مع
Great. Okay, let's go next, please.
Hi, next.
I'll if there is time, I can probably.
هاي الهيستوري واضح عندك؟
لا, بس first slide, left main bifurcation. I can't see.
شوي غريب ليش؟ طيب حتى
هسه مو طالع
هسه اوكي هسه بنعمل لك اياها ثواني.
Okay.
هيك واضح؟
Yeah,
تفضل.
So this is an 80-year-old male presented with he had severe dyspnea. He's known to have coronary artery disease with CTO of LAD since 2011. Chronic renal insufficiency, severe COPD. His BMI is 41 and his EF is 45 to 50%.
علي صوتك شوي بالله يا اياد، علي صوتك.
Yeah, okay. Yep. He also has moderate aortic valve stenosis. His CTO LAD was found in 2011. His BMI is 41 and he has chronic renal insufficiency. Next, please. So during this admission, his cardiologist was consulted. EF again 45 to 50%, which decreased from 60% in 2018. There's inferior hypokinesis, but there was no akinesis of the apical, septal, and distal inferior walls. Grade 2 diastolic dysfunction. Mean gradient across the aortic valve was 34 millimeters, and stress test in 2017 was or showed distal anterior and apical ischemia. At that time, his cardiologist recommended medical therapy. So he was taken to the cath lab during this admission. RCA is fine, as you can see. There are right to left collaterals to the LAD. There's that disease you see in the left main extending into the LAD and circ. And there is no antegrade flow in the LAD.
So, panelist, Dr. Wael, Dr. Raed.
He's a high risk.
How do you treat?
Yeah, he's a high risk patient, 8-year-old, moderate aortic stenosis, mildly to moderately LV dysfunction, and he has also COPD. So it's team approach. Definitely, I would get the surgeon involved, but I see this most of the time the surgeon would not take the patient to the OR. Okay. Especially you don't see also target on that LAD distally to bypass or do anything.
Dr. Raed.
I didn't see if the LAD has reconstruction at the mid or distal portion from the RCA. Was there a mid-distal LAD appearing from the right coronary artery?
Yeah. Can you, Dr. Mahmoud, can you go back 2 slides? I think.
Yes.
Yeah.
Hey. واضح?
I'm not seeing a good LAD there. Maybe it is diffusely deceased or maybe underfilled. So
could be underfilled. Yeah.
This is a complex patient. This is a man that, if you believe in syntaxis score 1 or 2, he has a high syntaxis score. He has a lower than normal ejection fraction. He has a chronic renal insufficiency. I think a heart team approach is a must here. Of course, we don't know what the patient will decide. But had the surgeons denied him, because the LAD appears there, the surgeon can find a target for the circ and the LAD and make it simple, like a Lima to LAD and a radial to or an SVG to the obtuse marginal. The RCA is okay. I would, if he's agreeable, go for bypass. If he is not, with his 80 years old chronic renal insufficiency, talk him about the risks. And I'm going to concentrate on left main circ because the LAD has been occluded since 10 years. I'm not sure I'm going to save anything, making it a complex CTO case. I could, but I would prevent that, make it short and simple for the sake of his kidney function. Do a left main circ approach and be done.
Okay. Any things? حدا حابب يضيف
I have a question. Yeah.
تفضل.
If we think he is not a big issue, because would we still ask a surgeon to evaluate the patient? I mean, the only the only advantage of CABG is Lima to LAD. So if we don't think this is necessary, why would we ask a surgeon to evaluate the patient?
زي مثل ما رائد حكى initially, it could be underfilled too. I mean, I would definitely get another opinion. It's not any procedure we do, regardless, high risk. So it's worthwhile to pause and discuss. And again, I want to emphasize على حكى الدكتور يوسف رقصوس الباشا على موضوع إنه the patient want that or so. This is even in the US and around the world. Physician guide the patient most of the time, more than 90% of the time, to what physician want. So it's so important to be clear with the patients, and because the expectation could be different from what we face later.
So if I may add something, Iyad.
Mahmoud, I would agree with the right.
With right, okay.
Go simple and safe. PCI, left main, and circumflex. Because the LAD is totally excluded a long time ago, since 2011. So this will not go ahead quickly for LAD circumflex.
The reason why we are saying that the LAD is important, but in this man with occluded LAD for so many years, he's been asymptomatic till the last few months. I believe his culprit will not be the LAD, it will be the left main circ. And with his renal insufficiency, his age, I would make it short and simple. Short, 10 minutes,
simple and safe.
And be out.
Yeah, but might be very calcified if he does an IVUS, and might be not short and simple. So IVUS might give you a different approach. So I'd leave it to Iyad to discuss.
تفضل كمل.
Yeah, sure. Because I believe that LAD is important to get back. I asked for a surgical consult. The surgeon came, evaluated the patient. He believed, let's give it a shot. If I'm able to probe the LAD fast, then we'll go for it. And the patient was fine with that, given all the comorbidities he has, and probably he will need a TAVR in a few years, probably 1 or 2 years. So it didn't really take too long. I'm a CTO operator, so it literally took less than 5 minutes to probe the LAD. Initially, I was able to cross the prox to mid LAD and landed it in a diag. I used a Pilot 200 with fine cross catheter. Then Pilot would not go in the mid LAD. There was another actually CTO segment, so I exchanged the wire out for Campions at 12, pushed down the mid to distal LAD. Then I stopped. It just did not feel right, so I exchanged it to Fielder XT, made a really nice small knuckle and pushed down in the distal LAD, confirmed being in the true lumen. Then, it goes just straight forward from there. So simultaneous kissing balloon angioplasty. I did high pressure balloon angioplasty of the mid LAD, proximal LAD, and left main into LAD, then simultaneous kissing angioplasty. And I prefer Kilot technique. I use the IVUS, as you see. Then I proceeded with stenting. I prefer the Kilot technique. I lowered a stent in the left main into circ. Then I keep that wire, in the LAD to guide me just in case for whatever reason I lose flow. So I crossed with a Pilot 50 down the LAD. And the easiest way to go is just go in the circ, then pull back, make that double J, and push your wire in the distal, across the distal struts, lift that strut up against the left main artery, and do more ballooning. Then I advanced a stent in the left main into LAD. Before deploying it, I believe I pulled the circ wire out. Then recross into the circ, balloon each artery at a time, and finish with simultaneous kissing at moderate pressure. I wouldn't go 12, more than 12 with a non-compliant balloon.
This is the final.
The stents I used across the left main into circ, I believe 3.5, and left main into LAD was 4.0, post-dilated each by more than 0.3 millimeters. The left main was 5 millimeters.
أبدعت. دكتور رائد ودكتور وائل، agree Kilot technique ولا بتحب تعمل DK crash technique؟
Okay, well, let me start on this. First, did you do an IVUS, Iyad, after you're done, since you have done it?
I did, but this was kind of a last-minute case, to be honest with you. I was prepared for another one. but Dr. Mahmoud asked to switch to this one.
That's okay. So excellent approach, excellent job. The only thing I would favor not doing Kilot here and favor the DK crush is because Kilot has been associated with some stent thrombosis in the follow-up, especially when you use it as a left main approach. So I would go for DK crush. Otherwise, it's an excellent result, especially if you have done an IVUS showing good apposition, good minimal luminal diameter, and so on and so forth. So good job.
Dr. Wael.
I agree with Raed. I would just go with DK crush, but it's excellent result at the end. هلا هو تعليقا على the just for the audience. You see there is a competition between the collaterals and the new artery. I'm hoping this will open up and but I agree with Raed. DK crush.
طب يا جماعة الزاوية هون مش الانجل it's more than 70 degree. What do you think?
This is what I wanted to. I'm a speaker here, but
75.
This is exactly going to my first presentation. So my friend here, Iyad, you have an angle between the LAD and the circ, which is more than 70
more
degrees.
Than 70 degree, yeah.
And you have a bit of a discrepancy between the circ and the LAD sizing, as you said. So this is not ideal for Kilot, unfortunately. This would have been a good one for DK crush, but I think you cannot beat success. It looks beautiful.
Yeah,
it looks beautiful.
Yeah. According to the classification, this is more than 70 degree. It's better to do Kilot technique. إذا أنت ماشيين بال.
I totally agree with and for respect, of course, to all opinions. I just don't like the fact that we have to crush metal, so you end up with three layers of stents across the distal left main, and most likely these patients, when they come back with instant restenosis exactly where that circuit is. Then you'll end up with even more layers. I totally agree with you, Dr. Abu Hantas, and thanks for your piece of advice. I can't argue. It's just my, for the last, I believe 6 years, I believe only one patient came back with instant restenosis across the left main when I did Kilot. It's anecdotal, I totally agree. But I believe that proper preparation of the vessel, as you presented, is a key here.
But you know, I think I would live with instant stenosis in a DK crush, but I would not live with a stent thrombosis. And this has been proven through studies that Kilot is associated with more stent thrombosis. Don't you think so?
Honestly, I mean, again, I've been doing, this is anecdotal, I totally agree with what you're referring to, but not even a single patient came back with instant thrombosis
أجاوبك على السؤال هذا يا دكتور رائد؟
تفضل.
ب3 ميتا اناليسيز اللي انعملت there is no difference in term of thrombosis. آخر دراسة اللي انعملت ميتا اناليسيز وpublished in JACC واضح جدا in favor of DKA crush comparing with the others. Not in term of mortality, in term of MACE, in term of revascularization, just.
And the major, some operators tend to skip, unfortunately, the most important step, in my opinion, which is finish with simultaneous kissing the one. They weren't aggressive.
Mahmoud.
Yes.
Mahmoud, هاي البيبر you are alluding to اللي طلعت في cardiovascular intervention this June.
Yes.
22nd of June 2020, huh?
Yes. أنا ببعث لكم يا دراسة
هي عندي أنا with fewer MACE driven by lower rates of repeat vascular with no significant difference among techniques referred to cardiac death, myocardial infarction, thrombosis. بس دي حقيقة كمل بعدين بدي أعلق على حكاية الدكتور هادي. تفضل.
يعني بالدراسات كلها ما في difference in term of thrombosis. The only difference حكينا إنه بالديكا crush it's better in term of MACE or in term of revascularization is better.
تفضل يا
دكتور محمد. أعطينا.
تفضل باشا.
تفضل يا دكتور.
باشا بدي أحكي خلي الباشا يحكي.
ألو.
تفضل يا باشا. طيب كمل يا دكتور وائل، شو بدك تحكي؟
لا أنا بدي أحكي يعني that's true in terms of studies. However, if you look at all expert people on left main, also they take in consideration the operator comfort. So if the operator is more comfortable in certain procedure, it would be better outcome per operator if he stick to that procedure and has second backup procedure, but bouncing between multiple ways might be not a good idea. So if Dr. Iyad has a good experience or excellent experience, what seems to be on such procedure, I would also, support what the operator likes to do. Because all of us, we do stuff, and I think sometimes you like a certain way and you're master on that, and you might be like thrombectomy is negative, but I do catheter thrombectomy so often, and rarely I don't get the clot out. So depend on the operator, I think what's his comfort level.
أبدعتوا جميعا. احنا 2 hours، احنا خلصنا السيشنز تبعنا. بنحييكم مرة تانية. دكتور وائل حسامي، بدي اياك دائما مش هيت اند ران، دائما بدي اياك تكون موجود معنا، وبوظ الاطباء الموجودين عندكم كمان. دكتور اياد من يونايتد ستيتس كمان ابدعت، وبدنا اياك دائما تكون موجود، والدكتور بهاء كمان، وكل الاطباء الموجودين. طبعا اليوم حضور 127، بعد ساعتين نزل 101 الان، 101 ل 103. انا بعد بتوقع حضور جيد. لسه الاخوان المصريين ما
محمود
العربي. تفضل يا باشا. احكي يا باشا، تفضل.
الو
تفضل.
سامعينك باشا،
سامعينك. انت مش ميوت، تفضل. طيب على بين ما يزبط شو اسمه
محمود.
خليني اكمل بس النقطتين. احنا بنحب كلكم تكونوا موجودين معنا، بدنا اعداد اكبر. انا حابب المره الجايه، وبدي تعاون الاطباء، بدي من السعوديه يكونوا انفولد معنا، من دول الخليج يكونوا انفولد معنا، يعني بتصير انتر اكتيف. الاخوان المصريين لازم دائما يكونوا موجودين معنا. فلسطين هذه انا بعتبرها دائما معنا، فلسطين ومصر هذول اقرب الناس الينا، يعني دائما معنا. واهلا وسهلا فيكم جميعا، ابدعتم كلكم. وبحب اشكر مره ثانيه، بحب اشكر الجي بي ام مره ثانيه، دعمها الكامل المتواصل.
محمود
يا باشا سامعينك.
تسمح لي اعلق بس كلمه واحده على محاضره هادي.
تفضل.
give an elegant presentation, short, concise about left main. وبدي take home message اللي حكيته انت ممتاز على الديكي كراش. بقول لك the question to be answered, why DK crush is technique described more than 10 years ago has not been generally adopted as the standard strategy for treating true bifurcation lesions. Possible reason, DK crush is a complex technique with additional provisional steps. Lack of familiarity may increase the potential for mistakes, and it's demanding. It's definitely the preferred two-stent left main technique for complex left main bifurcation. Definitely it's the standard. But in the same paper اللي محمود alluded to this last June في editorial comment من consensus papers from European Bifurcation Club after publication of the DK Crush 2 study still regard provisional stenting as the default technique for most bifurcation lesions and distal left medians. But DK Crush is the default for two-stent strategy as lower rates of target lesion failure compared to provisional stenting. والله يعطيكم العافية.
يسلم يا باشا.
Excellent.
احنا حاولنا 5 حالات أو 6 حالات نقدمهم بوقت ضيق، بس الخبر الجيد المحاضرة هذه راح تكون أونلاين خلال يعني ماكسيموم يوم الخميس راح تكون أونلاين. فالأطباء يعني اللي ما حضروها على اليوتيوب الأطباء اللي ما حضروها بيحضروها مرة ومرتين، لأنه فيها نواحي تعليمية على مستوى كتير ممتاز. الخبر الثاني، الأسبوع القادم يوم الأحد عندنا 2 cases فقط، 2 cases، وفي كيس صغير لدكتور إياس راح يقدمها theoretical 10 minutes. 2 cases، 1 case EP. هاي لأول مرة جماعة الإي بي راح يكون لهم حاله مشترك فيها دكتور محمد الحجيري، نزيه القادري، اسماعيل حمام، منير الزرقاء. 4 راح يكون انفولد. جماعه الاطباء اللي من الخدمات ما عندي مانع يعطوني اي واحد حابب تو انفولد، اهلا وسهلا فيهم. الحاله الثانيه راح تكون لمحمد الجعبري، interesting case فيها ديسكشن، يحضر حاله كويس محمد الجعبري لانه الحاله بدها جود ديسكشن. ماشي الحال، اهلا وسهلا فيكم جميعا، ونراكم الاسبوع القادم بيوم الاحد القادم ان شاء الله.
محمود بدي اسال وائل انت وين هسه؟ في بوسطن.
في بوسطن في ليهي باشا.
في ليهي، لازم يا عظيم ليهي. يا سلام عليك وعلى ليهي، انت مبدع
يحفظك باشا
يا وائل، والله العظيم. الله يعطيك العافيه،
انت معلم وفقر باشا. الله يطول عمرك.
تسلم. اهلا واهلا في رائد، واهلا في الشباب كلهم، وشباب مصر وفلسطين واليو اس اي. يعطيكم العافيه كلكم. شكرا
يا باشا. بدنا نضم الوطن العربي كله ان شاء الله. احنا
طبعا ان شاء الله.
ICIG مع جمعيه اطباء القلب راح نضم كل المنطقه ان شاء الله. يا الله يعطيكم العافيه، ونراكم الاسبوع القادم
ان شاء الله.
شكرا.
حياكم.
السلام عليكم.